What if I told you that right now, today, you might be making a mistake that could completely change the direction of your life? Not because you're irresponsible, not because you don't care, but because nobody ever gave you the full picture. Here's a number that should stop you cold. According to the World Health Organization, nearly 121 million unplanned pregnancies occur every year across the globe. That's not 121 million acts of carelessness. That's 121 million gaps in education. 121 million moments where someone trusted advice that turned out to be wrong, or trusted their body when biology had other plans. And here's what makes this even more uncomfortable. Many of these pregnancies happen to people who thought they were being careful. Today, we're going to talk about 7 specific mistakes, backed by medical research, that quietly and consistently lead to unplanned pregnancies. Some of these will feel obvious, others are going to genuinely surprise you. And one of them, mistake number 4, catches people off guard more than almost any other because it has absolutely nothing to do with what you think it does. No shame here, no judgment, just science, honesty, and information that could genuinely matter for your life. So stay with me, let's get into it. Stopwatch mistake 1, contraception misuse. Let's start here because this is the one that affects the most people and gets the least honest conversation. You've probably heard that the birth control pill is 99% effective, and technically that's true. But here's what they don't tell you. That 99% only applies under what researchers call perfect use, meaning taken at the same time every single day without fail, without any interference every month. In the real world, the pill's effectiveness drops to around 91%, meaning roughly 9 out of every 100 women using the pill as their only method will experience an unplanned pregnancy within a year. That's not a small number. That's a classroom full of people. So what creates that gap between perfect use and real-world use? Missing pills, taking them at wildly different times each day, not knowing what to do after you've been vomiting, finishing an antibiotic without knowing it could interfere with your pill. All of these create invisible cracks in your protection. And condoms, same story. Used perfectly, they're about 98% effective. With typical use, wrong size, improper application, or that condom you've had sitting in your wallet for 8 months, that rate drops closer to 85%. Here's a myth I want to destroy right now. Myth: antibiotics always make the pill fail. Fact: most antibiotics do not meaningfully interfere with hormonal contraceptives. The one major exception is rifampicin, used to treat tuberculosis. However, and this is critical, other medications like certain antiepileptic drugs and even a common herbal supplement called Sint. John's wort absolutely can reduce effectiveness. More on that in mistake 4. Practical tip: set a daily phone alarm for your pill, store condoms somewhere cool and dry, your wallet or your car glove compartment are not that place, and always check expiry dates. Yes, condoms expire. So contraception can fail quietly from the inside. But the next mistake, it's built on a belief that millions of people hold and it's medically wrong from the start. Stopwatch mistake 2, relying on withdrawal alone. Here's a question for you. How many people do you think use the withdrawal method, the pull-out method, as their only form of contraception? In the United States alone, surveys estimate that around 60% of sexually active adults have used withdrawal as their primary method at some point. 60%. Now, to be fair, withdrawal is better than nothing. But here's where the science gets uncomfortable. Pre-ejaculatory fluid, what people commonly call precum, can contain sperm. Research published in the journal Human Fertility found that roughly 17% of men consistently produce sperm containing pre-ejaculate, and they have absolutely no way of knowing which group they fall into. More than that, the effectiveness of withdrawal depends entirely on perfect execution under pressure, every single time. With typical real-world use, withdrawal carries a failure rate of approximately 20% per year. That means 1 in 5 couples relying on this method alone will face an unplanned pregnancy within 12 months. Myth: if he pulls out in time, you're safe. Fact: you can be exposed to sperm before withdrawal even becomes relevant. And if either partner has consumed alcohol or is highly aroused, the self-control required for consistent, timely withdrawal becomes significantly less reliable. Practical tip: withdrawal can be a supportive secondary method. Paired with a condom or hormonal contraception, it adds an extra layer. Alone, the math doesn't work in your favor. And speaking of timing, the next mistake is all about a very different kind of timing, one that comes down to how well you actually know your own body. Stopwatch mistake 3, misunderstanding the fertility window. Quick question: when during a menstrual cycle is someone most likely to become pregnant? If you said day 14, the midpoint of a 28-day cycle, you've been taught the most oversimplified version of reproductive biology possible, and that oversimplification causes real harm. Here's the truth: Sperm can survive inside the female reproductive tract for up to 5 days. 5 days. That means the fertile window, the period during which pregnancy is genuinely possible, spans approximately 6 days per cycle, and that window moves. Ovulation doesn't always happen on day 14. Stress, illness, sleep disruption, weight changes, travel, all of these can shift when ovulation occurs, even in someone with a cycle they describe as regular. Researchers have found that even in women with 28-day cycles, ovulation timing can vary by up to a week from month to month. And if you have polycystic ovary syndrome, affecting an estimated 1 in 10 women of reproductive age, predicting ovulation becomes dramatically more complex. Myth: you can only get pregnant in the middle of the month. Fact: you can conceive from intercourse that occurred days before ovulation. The egg itself is viable for only 12-24 hours after release, but sperm waiting inside the body extends the window significantly. Practical tip: apps like Clue and Natural Cycles use basal body temperature and cervical mucus data for more accurate tracking than a simple calendar. But remember, fertility tracking apps are tools for awareness, not substitutes for contraception in most cases. Now, I promised you mistake 4 would surprise you, and I meant it, because this next one doesn't involve contraception choices at all, it's about something you might already be taking. Stopwatch mistake 4: ignoring medications and health conditions. Imagine doing everything right, taking your pill every day, using protection, and still ending up with an unplanned pregnancy because of medication your doctor prescribed for something completely unrelated. This happens. And it happens because neither the patient nor sometimes even the prescribing physician connected the dots. Certain medications are what pharmacologists call enzyme inducers. They speed up the liver's metabolism of synthetic hormones, including those in your contraceptive pill. This means your body processes and eliminates the contraceptive hormones faster than intended, potentially dropping the level in your bloodstream below what's needed to prevent ovulation. Medications in this category include antiepileptic drugs like carbamazepine and phenytoin, certain HIV antiretrovirals, the antifungal griseofulvin, and this is the one that gets people St. John's wort, a herbal supplement sold over the counter in virtually every pharmacy in the US, UK, and Australia. Now here's another angle most people don't consider: gastrointestinal illness. If you vomit within 2 to 3 hours of taking the pill, your body may not have absorbed the dose. Same applies to severe diarrhea lasting more than 24 hours. The NHS, Planned Parenthood, and most reproductive health guidelines treat significant GI illness as equivalent to a missed pill, meaning backup contraception is strongly recommended for at least 7 days afterward. Myth: as long as you're taking the pill, other medications don't matter. Fact: several common medications, including supplements available without a prescription, can meaningfully reduce hormonal contraceptive effectiveness. Practical tip: every time you start a new medication or supplement, prescription or over-the-counter, tell your pharmacist or doctor you're using hormonal contraception. Consider a non-oral or non-hormonal method if you're on enzyme-inducing drugs long-term. And if you're sick with vomiting or diarrhea, treat that day as a missed pill. That's 4 mistakes we've covered so far. But here's something worth sitting with for a moment, because the next mistake involves something that happens in relationships every single day in complete silence. Stopwatch mistake 5: skipping the contraception conversation. In one large survey of US adults, nearly 1 in 3 people reported that they had assumed their partner was handling contraception without ever directly confirming it. 1 in 3. This is one of the most human mistakes on this list. Nobody wants to interrupt a moment to have a logistics conversation, and there's a cultural script that often places contraceptive responsibility entirely on one partner, usually the person who can become pregnant, while the other assumes the situation is handled. The result? 2 people both assuming the other has it covered, and neither of them does. There's also a more serious dimension here. Reproductive coercion: when one partner deliberately interferes with contraception decisions without the other's knowledge or consent, affects an estimated 1 in 6 women in relationships in the United States. This includes secretly discontinuing contraception, refusing to use condoms, or pressuring a partner around contraceptive choices. It is recognized as a form of intimate partner violence by major medical organizations, including the American College of Obstetricians and Gynecologists. Myth: contraception is one person's responsibility in a relationship. Fact: reproductive health outcomes affect both partners. Communication is not just emotionally healthy, it's medically protective. This is also the moment to talk about STI status alongside pregnancy prevention. A condom protects against both. A pill protects against neither one except pregnancy. Practical tip: before becoming sexually active with a new partner, have an explicit conversation. What are you each using? What would happen if contraception failed? It doesn't have to be a heavy conversation, it can be calm, direct, and quick. What it cannot be is assumed. Now, even in relationships where communication is great, a mistake can still happen. And when it does, most people turn to emergency contraception. But there's a lot of confusion about how it actually works, and that confusion can make it less effective. Stopwatch mistake 6: misusing emergency contraception. Emergency contraception is one of the most misunderstood medications in modern reproductive health. And the misunderstanding cuts in both directions. Some people are afraid to use it because of inaccurate information, and others rely on it in ways that reduce its effectiveness. Let's set the record straight. Myth: the morning after pill causes an abortion. Fact: emergency contraception works primarily by delaying or preventing ovulation. If ovulation has already occurred, it may have limited effect on fertilization. If fertilization has occurred, current scientific evidence does not support the claim that EC prevents implantation. It is not an abortifacient. This is the consensus position of the WHO, the FDA, and major obstetric organizations worldwide. Now here's where the practical mistakes happen. There are two main types of EC pill available in most countries. Levonorgestrel-based pills, sold as Plan B in the US, Levonel in the UK, and various names in Australia and Canada, are most effective within 72 hours of unprotected sex, but effectiveness declines significantly with time. Ulipristal acetate, ELA in the US, ELA-1 in Europe, is effective up to 120 hours and maintains better effectiveness across that window. Here's what many people don't know: body weight matters. Research has shown that levonorgestrel EC may be significantly less effective in people over approximately 165–175 pounds. If this applies to you, ulipristal acetate or a copper IUD are more effective options. And the copper IUD, when inserted within 5 days of unprotected sex, is the most effective form of emergency contraception available, with a failure rate of less than 0.1%. Practical tip: know your options before you need them. Check in with a pharmacist about weight-adjusted recommendations. And remember, emergency contraception is exactly that: emergency. It is not designed or recommended as a regular contraceptive method. We're nearly there, one mistake left. And unlike the others, this one doesn't happen in a single moment. It happens slowly, quietly in the background of everyday life. Stopwatch mistake 7: lifestyle factors affecting contraceptive reliability. The last mistake on our list isn't a single decision. It's a collection of daily patterns that most people never connect to their reproductive health but should. Start with stress. Chronic psychological stress elevates cortisol levels in the body. Cortisol disrupts the signaling between the hypothalamus, the pituitary gland, and the ovaries, what doctors call the HPO axis, which can cause irregular or delayed ovulation. This means even someone using fertility awareness methods may find their cycle becoming unpredictable during high-stress periods, expanding their actual fertile window beyond what they've calculated. Then there's body weight. Significant weight changes, both gain and loss, can affect how hormonal contraception is absorbed and metabolized. The contraceptive patch, in particular, has labeled guidance from the FDA noting reduced effectiveness may occur in people over approximately 198 pounds. This is a conversation worth having with your healthcare provider if your weight has changed significantly since you started your current method. Smoking deserves a special mention, not primarily because it affects contraceptive efficacy, but because combining smoking with combined hormonal contraceptives, those containing estrogen, dramatically increases the risk of blood clots, stroke, and cardiovascular events. This is particularly true for smokers over 35. It's one of the most overlooked contraindications in women's health. And finally, alcohol, not because it physically disrupts contraception, but because it reliably disrupts decision-making. Forgotten pills, skipped condom use, reduced inhibitions around backup contraception, these are real, measurable behavioral effects that translate directly into unintended pregnancy statistics. Myth: as long as I'm on a method, my lifestyle doesn't affect my protection. Fact: your body's response to contraception is dynamic. Stress, weight, medications, and behavior all interact with how effectively your chosen method works. Practical tip: schedule an annual contraception review with your GP, OB/GYN, or sexual health clinic. Discuss any significant lifestyle changes, weight, medications, stress levels, and ask whether your current method is still the best fit. Contraception is not a decision you make once and never revisit. So there they are, all 7, and now that you know them, let's bring this all together. Let me ask you something. Looking back at those 7 mistakes, how many of them were actually about carelessness? How many were really just about missing information? Almost all of them. Contraception used inconsistently because no one explained what consistency actually requires. A method relied on that science doesn't support. A fertile window misunderstood because biology class glossed over the details. A medication taken without knowing it was quietly canceling out protection. A conversation never had because nobody modeled what that conversation looks like. Emergency contraception used incorrectly because misinformation spread faster than facts. And lifestyle factors never connected to reproductive health because that connection is almost never made explicit. This isn't about blame, it's about information. And now you have it. Here are the 7 in 30 seconds. 1. Use your contraception correctly and consistently. 2. Don't rely on withdrawal alone. 3. Understand your actual fertile window, not a textbook generalization. 4. Check every medication and supplement against your contraceptive method. 5. Have the real conversation with your partner. 6. Know your emergency contraception options before you need them. 7. Treat your contraception as something that needs periodic review as your life changes. And above everything else, talk to a licensed healthcare provider. A GP, a gynecologist, a sexual health nurse, a Planned Parenthood counselor, a pharmacist. These people exist to answer the exact questions this video raised for you, specific to your body, your history, and your life. If this video helped you, share it with someone who needs it. And tell me in the comments which of these 7 surprised you the most. I read every single one. Take care of yourself. See you in the next one.